Hello everyone and welcome to Your Health, Your Choice. I am Dr. Roopnarine and we are coming to you live from our studios at Olira Heights in San Fernando. Tonight is Wednesday, the 9th of November 2022, and on tonight's program we're going to be talking about neurology. In studio with me tonight is Dr. Avidesh Panday. Dr. Panday is a consultant neurologist at the Eric Williams Medical Sciences Complex. As usual tonight, folks, our number should come up at the bottom of your screens, and myself and Dr. Panday will do our very best to answer each and every one of your questions during the program. So guys, we're going to talk about neurology, we're going to talk various topics in the field, and we're going to say hello to Dr. Avidesh Panday. Doc, welcome to the program. It's great to have you. Welcome to Your Health, Your Choice.
An absolute pleasure to be here. Thank you for having me.
Yeah, no problem, Avidesh, no problem. Doc, neurology is a really big field, and just having a discussion with you over the last few days, it's such an expansive amount of topics we could discuss, right? But thinking about it, we try to narrow it down to a lot of the topics that I think the population would like to hear, the audience, based on what comes into us in general practice in the community, you know. So tonight, we'll go through, hoping that we touch on Parkinson's disease. Okay. Hoping that we touch on some epilepsy and seizures. Okay. And I'm hoping that you give us some of your insight into migraines and headaches tonight as well, if we have time. Okay. All right. And during the course of the night, we'll be taking questions as well from the audience. All right. Some questions and feedback. Sure. So, Avidesh, let's just start off with the first thing being Parkinson's disease. It's a fairly common thing that we see in general practice. So if you could tell us a little bit about what is Parkinson's disease, and most importantly, how could our audience at home, how could the loved ones or family members, how could we ourselves recognize early enough symptoms to be able to help ourselves to come and see someone like yourself, a neurologist or a family doctor?
Well, you have certainly put me in the deep end of the pool there.
I know you're able. But you're the expert.
But the first thing is that most people that present to the primary care or to the neurologist with a suspicion of Parkinson's, it's always a tremor. It's always that they may notice a tremor, a loved one may notice a tremor, and they're like, ooh, this is Parkinson's. Right. So they come to you and they're like, Doc, do I have Parkinson's? Am I looking at Parkinson's here? So the typical presenting complaint is a tremor. But what I'm going to tell you is that most patients with tremors do not have Parkinson's disease.
Good point.
So just because you've got a tremor does not mean it's equal to Parkinson's.
Right.
The core component of Parkinson's disease is slowing down.
Okay.
So what you're going to see slowness of movement.
Right.
So the loved ones, they're going to tell you, you know, Doc, my relative is walking a little bit slower.
Right.
Doc, you know, my handwriting is getting a little bit slower.
Right.
Doc, I'm trying to speak to my husband or my wife and their voice is getting softer. Right. Now, of course, they may have a tremor, but the core component is slowness. I call it the 3 S's. Yeah. Slowness, shakes, stiffness. Right. So your body is no longer moving like John Travolta. Right. Back when you were young, you're moving more rigid.
What you described there, Avidesh, is like a real subtle change, more than what people would think, you know.
Absolutely.
And it's almost like people will say, well, I'm getting older, you know what I mean? Or your parents or the caregivers might say, well, mommy, daddy, obviously you're getting slower, you're getting older. But you're saying that's not necessarily so. Being slower, it could not be not a natural part of aging. It's actually that the person may have
accelerated.
Parkinson's.
You've mentioned a very important point there, which is the time course.
Yes.
From the time you noticed a fairly acute, meaning days to, you know, a new onset slowness within days, that's a red flag. It's unlikely to be Parkinson's because Parkinson's develops over many months to years. Right. In fact, it's so slow that many persons think, oh, this is just natural aging.
Yes, that's the point I was getting at.
Until it's so far along that you can't miss it.
Right.
So it's age inappropriate slowing.
Okay.
And very often it takes someone who's not seeing that person every day to really point it out to you.
Because they recognize the sudden change.
Exactly. So it's the typical story is somebody you haven't seen in 4 or 5 months, someone from abroad coming and seeing you and saying, that's not the person I know.
Right.
And remember the core features. For the primary care physicians out there, for the physicians out there,
caregivers,
the 3 S's: stiffness, slowness, and shakes.
Okay.
But the key component, slowness.
Okay. What are the age groups that you'd expect to see this illness?
Well, Parkinson's is what we call a neurodegenerative condition, which means that unfortunately there's no cure for it.
Yeah.
So the older you get, the more likely you're to develop symptoms. But I have seen patients in their 30s, early 40s develop Parkinson's. But generally speaking, late 50s, early 60s. But even in a patient who presents in their 70s, you go back into the history, symptoms were there long before.
Okay. So I suppose you really have to keep a close eye as a healthcare professional on your patients, even though they're coming in for different stuff. You have to different medical complaints. You have to keep a close eye on them because you recognize the changes as well.
Well, if you've got a patient that you've been seeing regularly in private practice or in primary care, in primary care,
yes.
From the moment they walk into your office,
we should pick it up.
You're going to pick it up because you're going to say, this is not the person I know.
Yeah. So, Doc, if you could just, I mean, you give us the 4 S's there, 3 S's. If you could just give us a little bit more of a description of some of the features of someone with Parkinson's.
Well, I like to break up Parkinson's into 2 major categories.
Okay.
We focus on the motor, meaning what we can see, the movement, the stiffness, the slowness, the shaking.
Yes.
But there are other components to Parkinson's which cause more problems, more issues, and it goes undiagnosed or people think it's unrelated.
Right.
Constipation.
Right.
Unexplained dizziness because of drops in your blood pressure.
Right.
And as I would have just told you, that one of the things about Parkinson's, it's more in the older population who also have hypertension. So a patient may present with frequent falls, and when you really get into it, their blood pressure is dropping because patients with Parkinson's tend to have fluctuations in their blood pressure. Memory impairment, so cognitive impairment. So when you speak about Parkinson's and you're examining that patient, you don't just look at the physical. You have to ask about loss of smell, cognitive function, constipation, frequent falls, balance issues, problems with swallowing, problems with speech. It's quite multifaceted.
Is there any other sort of mental issues? Would they get depression?
Yes.
Could you speak to that as well, please?
Yes. With most neurological illnesses, but specifically with Parkinson's, there's quite a lot of anxiety. Early on, quite a lot of anxiety. And as you know, anxiety is a stepping stone to depression.
Yeah.
So patients can go from anxiety into depression or straight into depression.
Right.
Now, one may say, but if I have Parkinson's and I was previously a fit and healthy person, obviously I'm going to get depressed.
Yeah.
But it's not that. And if I may, just to touch on it briefly, the basis of Parkinson's is a chemical imbalance. So many times we send patients for CT scans, MRIs, and all of these things. They come back normal. And you're saying, how can I have Parkinson's if my scan is normal? Because it's not a structural problem. It's a chemical problem.
Which you would not pick up on.
And you're not going to pick that up on conventional imaging. So with that being said, you're going to have, and the basis of anxiety, mental illness, depression is a chemical imbalance. So that's why patients with Parkinson's have these comorbid psychiatric components to these things. How I put it is like this. Your brain is like a car. Your car is in tip-top shape. That's why the MRI looks good, but you have no gas in the car. That's why your car cannot move. And that's the basis of treatment of Parkinson's, which we can always talk about later.
Very good. That's really interesting. I really appreciate how you try to explain to our audience that don't look beyond the physical, look beyond what is obvious in terms of the slowing down of the patient, and look for other features. And these other features which we might put down to aging or patient that's getting old, other sort of non-physical features, depression and so on, constipation, those are things that we have to look out for, and that might be someone who's also suffering from Parkinson's disease as well.
Absolutely.
And I must credit you for bringing forward that point, because that's something that might be missed by a lot of caretakers and medical professionals as well.
There are lots of studies which show that patients are more bothered by the non-motor symptoms than the actual slowing down of Parkinson's, and it causes more morbidity. These patients lose confidence, they don't want to go out, they become recluse, these sorts of things.
So in terms of cognitive ability, can you just explain that to the audience as well, what that means?
So when we speak of cognitive ability, we speak of brain functioning. So many times we talk about, well, if something's wrong with the brain, we're going to have problems with weakness, or we're going to have problems with mobility. But the brain is more than just that. The brain is functioning. So when we speak about cognition, it's an all-encompassing term, inclusive of short-term memory, directional sense, which we call visuospatial, appropriate emotional and reactive behaviors to situations, verbal fluency, memory for names. So it's essentially how our brain functions. And just to speak about it briefly, but Parkinson's goes hand in hand with dementia, because an aging brain, which is what we see with a neurodegenerative process, will ultimately lead later on to some sort of cognitive impairment. So in Alzheimer's dementia, the major problem is short-term memory. But in Parkinson's, yes, there may be some degree of short-term memory, but it's a lot of behavioral changes. So these patients, they're sharp, they remember a lot of things, but you find they become easily irritable. They may see things that are not there. They may become less able to perform executive function. Typical example, a person could go to the bank and do all their transactions. All of a sudden, you're noticing the bank is calling, there was a mistake on this form. You could have gone to the grocery, bought 10 items without making a list. All of a sudden, you're coming back home, you're forgetting 2 or 3. That's executive function.
All right. The common question that someone at home might ask is, how would I know if it's just routine, normal forgetfulness, or is it dementia, aka or part of Parkinson's? How could someone tell the difference? How do you tell the difference?
Well, that's a phenomenal question. And the reason why I say that is because it's almost impossible to really know what is the what is real, what is going on, because first of all, you should never come alone to a visit. We need someone there. That's called collateral history.
And I think that's important for not only for you, a neurologist, but I think
everybody.
I think everyone should, especially the elderly, come with a relative.
Exactly.
We still have people sometimes coming on their own.
And so what I do is we do something called MOCA test, which is also called a mini mental state, which is just a lot of questions, and we tabulate that score, and we do it without any prompting from the relative. Then we start to ask the relative about what symptoms that they are seeing. We put it together, and then we realize what is normal, what is clear-cut dementia, and then there's a middle ground, which is called mild cognitive impairment. Mild cognitive impairment is where you do okay on your tests, but your relatives are like, look, this guy is not functioning as they should, and that is the patient who may convert to full-on dementia within a year or 2. And then, of course, there is the fourth category, which is called pseudo-dementia. If I'm telling you something right now, but your mind is distracted elsewhere, you're not going to remember what I'm telling you.
Exactly.
That doesn't mean you've got dementia. It just means you weren't listening to me. So if you've got an anxious person or a depressed person, they may be focused elsewhere and maybe misdiagnosed as dementia.
Right. Excellent description of it again. A common question, what causes, or is there any attributable causes in terms of genetics or environment or diet or foods we eat that might contribute to Parkinson's disease? Well,
first of all, it's a bit of everything. There are the genetic causes of Parkinson's. It's very rare.
So if your parents have it, you're more likely to have it.
To some extent.
Okay.
It does not mean that you're going to have it, but there are some genes which are strongly associated with Parkinson's, very, very, very rare. And but of course, if your family has it, you have got a higher risk than the average person. In terms of exposure, we all know Muhammad Ali. That there are links with traumatic brain injury and the development of Parkinson's later on. In terms of diet, believe it or not, and I'm going to make a little controversial statement here. There has been some talk, especially coming out of Guadeloupe, of soursop, an association of long-term soursop consumption and the development of Parkinson's. Of course, that's experimental, but there is some sound data there.
All right. So that's somebody who's really eating soursop, I suppose.
I guess so. I'm not much of a soursop person.
All right. And then the converse would also be the question, is there anything that we can do in our terms of our diet or our foods or the caretakers? Let's say we have an established person with Parkinson's disease. Is there anything special in their diet or their food that the caregivers and relatives could add in to help them function better or even slow down the progress of it? And we're not talking about medication, but in terms of diet and activities at home that they could do to help them.
Absolutely.
Yeah.
I am very reluctant to initiate medication on a lot of patients with Parkinson's. If you are limited in your daily activities and there's been a discernible change in your ability to perform, of course I will initiate medication. But every large trial has repeatedly shown that exercise has been proven to reduce all symptoms, motor symptoms, stiffness, slow, and shakes in Parkinson's. In fact, bicycle riding, stationary bicycle, because your balance may be off, so don't go.
Right, of course.
Ballroom dancing, kickboxing or shadow boxing, brisk walking.
Because of the coordination practice.
Absolutely. So what all of these exercises have in common is that the use of core strength. And what that does is it limits your slowness, it limits your shaking.
And protects you from falls as well.
Absolutely. So it doesn't make sense you stress medication. Of course there is a time and place for medication. Of course if you're having a lot of symptoms. But in every early diagnosed patient with Parkinson's disease, you ought to repeat the mantra of exercise and where possible engage a physical therapist for fall prevention strategies, for surveillance, to be looking at their gait to say, look, there's a change here, you can fall going down the stairs. And the other thing is that, walking is good, but there are better exercises than simple walking with Parkinson's, which I've told you about, dancing, etc. And last but not least, stretching. In Parkinson's, your body wants to get stiff. So how do you counter that? By stretching. So prior to your workout, stretching is important. Prior to going to sleep, stretching is important. First thing in the morning, stretching.
To counter that stiffness that's going to develop.
It takes only 2 to 3 minutes.
That inclination towards spasm.
Well, we don't use the word spasm.
Stiffness?
Rigidity. Yeah.
Rigidity. Now, is there any foods that would help the person with Parkinson's, suffering from Parkinson's?
Not really, but if you if you are on medication, specifically levodopa, which we call Cinemat,
which is the baseline, the most common medication for Parkinson's.
Going back to the car analogy, that's like you putting gas in the car. So when you take the levodopa, you are refilling the tank, so your body starts to
That's the chemical that we need.
Absolutely. One of the mechanisms by which there's less absorption of the medication is if it's taken with meals. So it's highly advisable that you take medications 1 hour before meals and limit your protein intake with the medication, because it reduces absorption of the medication.
Okay. All right, Doc. So I think now is a good time for us to take our first break.
Okay.
All right, guys. We're here with Dr. Avidesh Panday. We're talking about neurology, we're talking about Parkinson's disease, and we're going on to talk about epilepsy, seizures, and hopefully we have enough time to speak about headaches. It's been a really engaging discussion so far. He's given us some great tips, great advice, focusing our minds where sometimes we might not see. So guys, I'd just like to formally invite you to send in your questions and your comments to us, and Dr. Panday and myself will do our very best to address them. And yeah, we're going to take a short little 1-minute break, and we'll see you back in one moment. Thanks, guys.
Doesn't scare me, it's not big enough. I'll never be the same. Never, never, never. I'll never be the same. In Jesus' name.
And when God sends a word, it serves a purpose. It serves a purpose because you serve a purpose. When you hear no, I want you to think next. So if God didn't let me do that, next. Jesus didn't call them to leave their boats. He called them to push out a little. It's a little decision so that I would rely on the grace of God. It's the blessing of both.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Avidesh Panday, and we're talking about neurology. Again, please take advantage of the opportunity to interact with Dr. Avidesh Panday. I know this is a lot of you caregivers out there, a lot of you out there involved in geriatric care. Please, you must have your questions, you must have certain comments that you want to make, certain information that you need to help your patients at home and to help your loved ones. Now is a great opportunity and a nice environment to ask an expert such as Dr. Avidesh Panday your questions. So Doc, let's just move forward a little bit from the Parkinson's and let's talk a little bit about seizures and epilepsy a little bit, right? If you guys give us a little idea about it's a common problem. We see we all have friends or relatives or someone we know who suffers from seizures. Mm-hmm. If you could just, but it seems like a sort of mysterious, almost semi-taboo sort of a topic still in Trinidad. If you could just give us a little explanation as to what is seizures, what is epilepsy, how does it come about?
Well, you've gone from Parkinson's, which is the older age spectrum.
Yes.
And you've now gone into seizures and epilepsy, yeah, which is the younger spectrum.
Yes.
So it's mainly a neurological illness of childhood.
Right.
That's the predominant demographic.
But not all seizures are epilepsy.
You know, you are a neurologist. You're very good because you just took the word right off my mouth.
Yeah.
I was going to tell you that.
Yeah.
Not everybody with a seizure, yeah, has epilepsy, but yeah, everybody with epilepsy has seizures.
Yeah.
So if I were to deprive you of glucose,
yeah,
you're going to have a seizure.
Exactly.
That doesn't mean you have epilepsy.
Exactly.
It means that you've got a precipitated seizure because of a correctable problem.
The reason I wanted to highlight that, right, is two things. Somebody might suddenly have a seizure, and their family and friends and whole community might be thinking they have epilepsy. And they might be giving them information about epilepsy, thinking they're not curable, and they have epilepsy, whereas they might not have epilepsy, might just have a very simple cause of a seizure that could be very simply treated and cured as well.
Absolutely. And
so it's not a no-hope situation, and it's not a hang-head situation, you know?
Well, I would go one step further.
Yeah.
It's not only a no-hope situation, it's not a no-hope situation, yeah, but it's a potentially dangerous situation.
Yeah.
Let me explain.
Yeah.
you've got these recurrent seizures,
Yeah.
and you think you've got epilepsy.
Yeah.
You see Dr. 1 who starts you on medication X.
Yeah.
You continue to have seizures because you really didn't have epilepsy. You
Yeah.
see Dr. B who puts you on medication Y.
Yeah.
And then 5 years later,
It is-
you've perpetuated an illness you've never had,
Yeah.
and you're on multiple medications,
Yeah.
and you've been on multiple side effects of said medication.
And the root cause
Has never
been explored.
found. So this is why when you've got a diagnosis of epilepsy,
Yeah.
you've got to make sure that these were not precipitated seizures and you've ruled it out. I'll give you an example.
So would you say that epilepsy is a little bit of a diagnosis of exclusion, so to speak?
It's not.
Or that you look around as well before?
Absolutely.
Yeah.
And 9 out of 10 times,
Yeah.
you can ascertain the diagnosis based on the history.
Yeah.
So for example, if you see a 50-year-old
Yeah.
with a first-time seizure,
Yeah.
you're going to start thinking, this is probably not epilepsy,
Yeah.
because if it were, they would have had seizures many
Okay.
years ago.
Right,
And
right.
then just today,
Yeah.
I saw a patient referred for epilepsy,
Yeah.
but this patient only has seizures,
Yeah.
but they are not seizures. They are fainting spells
Yeah.
only on physical exertion.
Right.
So that obviously tells me unlikely to be
Yeah,
epilepsy. So
yeah.
I am looking at a cardiac,
Electrolytes or cardiac or
workup
different-
and that sort of thing. So
All right. Doctor, I just want to pull you back a little bit now. So what is epilepsy then?
there's technical definition and then there's a simple definition.
How would you
which
diagnose someone with epilepsy?
Epilepsy is defined as abnormal brain activity which leads to either a physical or non-physical neurological abnormality.
Right.
So for example, when we hear epilepsy,
Yeah.
we think this.
Shaking and seizures.
Shaking and
tonic-clonic.
that's called convulsions.
Yes.
But this could be a seizure. This could be a seizure.
Yeah.
So
Yeah.
a seizure is an abnormal physical movement
Yeah.
or lack of a movement
Yeah.
due to abnormal electrical activities
Yeah.
in the brain.
Yeah. And I'd just like you to repeat that for a very important reason, Doc. The general population thinks seizures are exactly that. And sometimes somebody might be having a seizure in front of them. And as a lot of people are first responders. The public, your relative is your first responder. So sometimes it's not only this that is seizures, but twitching, twingling.
I believe that really and truly one of the key personnel who would be able to diagnose seizures early on are teachers.
Exactly.
Because teachers see children every day
Yeah.
and they are able to give a visual, graphic demonstration of what symptoms the child may or may not exhibit.
Yeah.
So I believe the most important thing about epilepsy and seizures is a full description. No detail
Yeah.
is minute.
Yeah.
So I actually tell patients or relatives who've witnessed it, act it out. Tell me exactly what
Yeah.
you've seen.
Yeah. And as you said, not only are generalizing, but it could just be the mouth twitching
Subtle
or
movements.
subtle movements that could represent
there
it.
is something called loss of awareness
Yeah.
versus loss of consciousness.
Yeah.
Because if you've lost consciousness,
Yeah.
you're not responding, you've blacked out.
Yeah.
If you've lost awareness,
Yeah.
you may be looking at someone, but you're not aware, and you can have seizures with both of them.
Right.
So the important thing about seizures and epilepsy is abnormal movement from what is normal,
Yeah.
return to full functionality or or pre-event, whether it's 1 hour, 2, 3 hours after,
Yeah.
and then the appropriate clinical investigations.
All right. So, what is the age group for epilepsy?
Any age.
Any age.
Any age, but the key pediatricians are usually the ones who encounter seizures the most. Many of my patients were diagnosed in pediatrics and have been transitioned from pediatrics into adults.
All right. How would you investigate someone for epilepsy?
Well, after we take a good history and
course.
examination, we start with basic blood works, make sure that there is no electrolyte abnormality.
Exactly, yeah.
And then we usually go straight to what we call electroencephalography or an EEG.
Yeah.
Now, EEG is like, when we have an ECG,
Yeah.
but instead of putting it there, we put it on the scalp.
Okay.
It takes about 20 to 40 minutes.
Yeah.
And it's it gives us an idea of what's going on in the brain.
Okay.
And then from there, we move on to imaging, such as a CT scan or an MRI.
Right. And once you have that diagnosis, I suppose you put the patient on treatment for the illness?
Well, not every patient with epilepsy goes on treatment.
Okay.
And not every patient who is on treatment stays on treatment. Okay. We can talk about that.
Why would you not give a patient who has epilepsy treatment?
Because the question is, and I'm going to ask you a question, because you see lots of pediatric patients, you see lots of people. Why do we treat patients with epilepsy? What is the core tenet of treating a patient with epilepsy?
Well, I suppose we don't want them to go through the, if they're having the attacks, safety. The attacks.
So if we've got someone with epilepsy and they lose consciousness, they may fall, they may hit their head. If they're bathing in the river by themselves, they may drown. And then, of course, every time you have a seizure, there is obvious problems like short-term memory and so on. So your school performance.
So we try to prevent the episodes from happening.
Absolutely. So the purpose of treatment of seizures are to prevent seizures.
Correct.
But there are some patients that may have one seizure a year.
Okay.
And they may have an obvious precipitant, for example, flashing lights.
Okay.
So are we going to subject that patient to medications with side effects which can alter their school performance when we could avoid the treatment?
So I suppose, good point. You give the medication to suit the severity of the illness. It's tailored or titrated towards.
It's tailored to your age, your educational goals, your safety parameters. So, for example, an offshore worker will be different from someone who drives a PTSC bus, or someone
I don't think that's necessarily. They might fall in the same category of bakers.
I guess same category, or someone who has a job where it's not on heights or not driving, these sorts of things. So it's tailored to your situation.
Okay. So what the goal of treatment is someone not to necessarily have seizures, right?
Correct.
Is there a cure for epilepsy?
Yes and no.
People want to know that.
Yes and no. If you've got seizures and you've had seizures and there's a structural problem in the brain, so for example, you've got seizures because of a tumor, and you remove the tumor, there's a very high likelihood you may not have seizures, and by definition that is cured.
Okay.
So if you've got a structural brain lesion and you remove that structural problem,
you won't have the seizures.
Exactly. But the vast majority of epilepsy is not cured, it's managed.
Okay. Our patients, I'm going to give you, our patients in Trinidad and Tobago well managed on epilepsy, because that's a hard question. Is it the goal of treatment that someone does not have seizures? And if someone is still having seizures on treatment, is that a failure of treatment? Do you understand the question I'm asking you?
That's a good question.
Yeah.
In my view, I think, and everything is comparative, compared to nations of similar economic status as Trinidad, I think we are reasonably well controlled in terms of not reasonably well controlled. Our success rate is quite good in terms of provision of medications on the CDAP, which is actually quite good. We have patients who can have access to these investigations.
I mean, that is the number one challenge in the Western world for epilepsy patients. And not talking about Trinidad alone, we're talking about this general part of the world, is the access to medications, isn't it?
And the truth of the matter is that patients do have access to medications. And
especially in Trinidad.
And yes, and these medications are medications that work.
Right.
Now, of course, there is a subset of patients which are known as medically refractory epilepsy, which is continued seizures despite 2 or more medications.
Right.
And the reality is that even if you've got the best medications in the world, it's not going to work on these patients. So those patients require further investigations.
All right. Doctor, may I ask you something? So if a patient comes into your office and goes, Dr. Panday, I've had seizures, thanks for giving me this medication, thanks for diagnosing me. Will I get a seizure again? You give me the medication. Does this mean I wouldn't have seizures anymore because I'm on your medication that you have given me?
And the answer to that is I can't say. If I said yes, you will not get another seizure, I am lying to you. There's no way that I can know if this medication is going to work, because different people respond differently to medications in terms of efficacy and side effects. And I'll need 1 minute to talk about this.
Go ahead.
The greatest parameter for success of treatment of medication is compliance. And a barrier to compliance is not availability, it's side effect profile.
Agreed.
So if a patient has got side effects, they're not going to take their medication, or they're not going to take the medication at the correct time or at the correct dosage, and then they're going to still have seizures. But is that failure of treatment?
In general practice, patients will ask about side effects. Generally, or a lot of them do nowadays. And I think it's the onus is on us. Your opinion might differ, but we could not agree on things. The onus is on us as medical practitioners, not necessarily to highlight the 100 million different things, but at least to explain to the patients that what possible side effects may happen. The scariest thing is, and explain to them what could happen, explain to them what we will do if it happens, and explain the plan if something goes wrong. I think the worst thing is for someone to enter into something thinking that nothing going to go wrong, or not being told that nothing going to go wrong, or they might not have a side effect, and when they encounter it, it's unexpected, and it makes them want to not comply with medication. I believe in educating them about some of the side effects, and obviously leaving the line of communication open so that if they do have this side effect, they say, hey doc, you told me this might happen, it is happening, thanks for, you know what I mean, thanks for reaching out to me today, and then we decide how to move forward from there. And that keeps people compliant.
Exactly, and one of the important things that...
Would you agree?
I agree,
right.
And this is where I believe the primary care has a big part to play.
Yeah.
We are limited in the amount of neurologists, the amount of neurology clinics there are, but there are quite a lot of primary care facilities. Addressing side effects is important, and managing expectation.
Exactly.
But there are three things that must be spoken about in side effects. The common side effects, and in the case of females, fertility and fertility/contraception, as well as potential adverse effects to a developing baby. So this is why when you see that subset of patients, it's very important that you discuss potential side effects.
Good point.
Two of these medications, because by the time you do a pregnancy test and it's positive, you've already been 8 weeks, and that's major organogenesis.
Good point.
So the three things that I always like to stress that physicians must talk about in the typical side effects: 1, pregnancy and woman's health. And finally, if you're an older patient, if you're on blood thinners and medications that can interrupt.
Great point, Doc, and I'm glad you brought that forward. But I just want to ask you again, what is the expectation for someone who's taking the medication? You don't know for sure, and that's basically you tell me that it's you may still have seizures, and we will have to adjust the medication.
The expectation when a patient comes to you and they've diagnosed them with epilepsy is that, 1, you want to make them seizure-free.
Exactly.
That's what.
But that's the question they're asking you: will I be seizure-free?
And the answer to that is 50 to 60% of patients are going to be seizure-free with one medication, and about 14 to 20% are going to be seizure-free with about 2 medications. So the other thing is, out of that cohort of patients, they're going to have side effects. So you have to manage expectations, but let them know, look, you're getting side effects. Let's address them and switch if necessary.
Just a big thing about people with seizures, right? With epilepsy, sorry. You kind of touched on it in terms of the job and the occupation. Give us, in general, guideline. Can somebody with seizures go back to driving? When can they go back to driving? When it will be safe to them to go back to the job? Is there some jobs that people can't do forever? It seems to me that you hear different timelines and different things coming back from the medical professionals themselves, the neurologists, and from the internet and different sources. If you could just give us a general guideline as to those different areas. You know what I'm talking about.
Exactly.
Yeah, so tell us, when can I go back to driving if I had a seizure?
If you would have a seizure, and I would tell you, you can't drive, you can laugh at me and say, make me. Because the
or stop me.
Stop me.
Yeah.
How can I stop
nobody
you?
can stop.
Because there's no law. There's no law. And that's
no, but
so that we could guide, but it's up to the patient to follow. Because or if there were a law. So for example, in North America, in general, if you've got a seizure, you cannot drive for 3 months. And
3 months.
3 months. If that's but if you're driving, for example, a truck or class, whatever class it is, it's 1 year.
All right. No, nobody can make anybody do anything unless it's law, right? Yeah. But we live in a society where we show goodwill to man and we show goodwill to ourselves and to our family.
So I will give you
we have a responsibility.
So
give us the recommended dosage.
So first,
time frames.
So generally speaking, if you've got a seizure, you should not drive for 3 months unless you're seizure-free for 3 months.
Okay.
If it's a commercial or industrial equipment, generally 1 year.
Right.
There are safety parameters that should be managed, and your human resource department would look into it. One, avoidance of heights, avoidance of open bodies of water, avoidance of open flames such as fires and all the ovens and these things, not using industrial strength equipment such as forklifts, jackhammers and these sorts of things. But most important, avoidance of night shifts and shift work.
Because it stresses you.
You need to sleep. And if you have to sleep and if you do shift work, you're sleeping at different hours, you're taking medication at different hours. So avoidance of shifts.
All right, that's very good. We're going to take another break, and then when we come back, we'll talk a bit about headaches.
All right.
All right, guys, so we're going to take a little break. We're here with Dr. Avidesh Panday. Please send in your questions, pick his brain. Let's get a discussion going. All right, guys.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture. ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. Yeah, Josh, I think you have some questions for us. I think we'll go straight into the questions and get the conversation going. So, Doc, good night. Your program regarding neurology. Is weight loss the only natural way to control intracranial hypertension? Not exactly what we were discussing, but it's neurology. What do you think about that? What is intracranial hypertension, and what are the ways to control it other than weight loss?
You were going to talk about headaches, right?
Yes.
And that's one of the common causes. Well,
yeah.
I wouldn't say common, but one of the common complaints that I would get in the neurology clinic. Mm-hmm. It's usually this is where patients may have headaches, visual symptoms, ringing in the ears, and it's usually incidentally discovered on an ophthalmology visit.
Yeah.
And what you have is you've got raised pressure in the brain because of excessive fluid.
Yeah.
So this excessive fluid may be because of excessive production or a delay in removal from the brain.
Right.
And it's usually seen in patients who've had rapid weight gain or an increase in weight. So yes.
Men and women?
Predominantly women. There's a hormonal basis to it.
Okay.
And what we usually advise, the most natural way to improve the situation is lose 10 to 20% of your starting body weight.
Wow. What do you mean your starting body weight?
So if, for example, I've diagnosed you and your weight is 200 pounds,
yeah.
10% is 20 pounds, and I say if you're a lady, do 20%. So if you get pregnant, you have a little bit of weight gain to...
and the headaches settle down?
Yeah, the intracranial pressure generally tends to improve. Now, of course, this is a very generalized statement, but common things being common, the question
it's a percentage game you're dealing with.
The question is correct. That's the most natural way. Of course, there are medications which we talk about.
Right, so weight loss does help?
Absolutely. In fact, in most cases, weight loss is not only going to help, it's curative.
Right, and so it's the best way.
Best way.
And then there's also medications that you could use.
Absolutely.
All right, viewer? I just wanted to make sure that we answer that weight loss is the best way to solve that problem. That's why the doctors keep hammering on it. And
10
there's
to
also
20% of what you're weighing at the time of diagnosis.
All right, cool. Josh, next question, please. Does autoimmune have any connections with your discussion?
Absolutely.
Yeah.
As with any medical condition or any illness, any part of the body, there are autoimmune causes whereby the body attacks itself. Some of the common examples of autoimmune conditions in neurology would be multiple sclerosis, or if patients have lupus, it may affect the brain, and it manifests with maybe seizures, personality changes, mobility issues, these sorts of things.
And I suppose there are any other sort of rheumatological or immunological conditions that affect the brain as well, any other diseases?
Absolutely. So rheumatoid arthritis.
Rheumatoid arthritis does?
It can affect the spinal cord.
Right.
Then, so the neurological system is divided into the brain and the spine, which is the central nervous system, and the muscle and nerve, which is the peripheral nervous system. So a lot of autoimmune conditions can affect the nerve and muscle.
Right.
The connective tissue disorders.
All right, cool. Josh, let's get the next question there, please. Doctor, you mentioned chemical imbalance. What is the chemical? Can a blood test tell you that there is an imbalance of this chemical? I think that's a very good question.
Good question.
Because you mentioned a chemical. So go ahead and answer that question.
So in Parkinson's, the chemical problem is dopamine.
Yeah.
In anxiety and depression, it's serotonin.
Yeah.
So unfortunately, a blood test is not going to help you because these are chemical components within the brain. And a blood test is in the periphery. So there's no correlation between a blood test as well as your clinical condition.
Can a blood test tell if there is an imbalance?
Of course, in some patients you may have hypothyroidism,
Yeah.
whereby the thyroid levels are low,
Yeah.
and that is a test you can look into. So that's one.
All right. So in Parkinson's, the chemical is called dopamine.
Yes.
And the medication is called levodopa.
Exactly.
All right. Josh. Doctor, good night. I had meningitis and I was at Mount for 1 month and had a stroke, but 90% good. And no feeling on the left foot from ankle to toes. I think a little bit was lost in Josh back and forth trying to get through the text message. But do you get the gist of what that patient is saying?
So this patient, and I'm very happy that
or this viewer,
this viewer has had a recovery, and that's very good because meningitis, especially if you've been warded for a month, carries a lot of neurological abnormalities, disability, and I do not believe that the stroke is the cause of this symptom because they're saying from the knee to the ankles. So what I suspect probably is that when you were when you've got meningitis, you've got an altered consciousness. You may have put your foot in an abnormal position for some time, and you've got a nerve compression from your foot against the bed railing.
Yeah, because you've been in and out of consciousness for such a long time.
If you were to have a stroke, it probably would have affected the left side, the entire left side of the body.
Might not be just limited to the legs alone.
Absolutely. So I would tell that viewer that there's absolute hope for recovery, and this patient may require some physical therapy or nerve conduction study.
Can you just talk a few sentences, because we have a few questions backed up, but it's very important. What is meningitis?
Meningitis is, if I open the skull, I'm not going to see the brain. I'm going to see a wax cover around it. And that is an infection of that wax cover. So meningitis is itis, inflammation, meninges, inflammation of the meninges. So you can have bacterial, viral, fungal, depending on the microbiology.
Okay. Josh is just whispering in my ear that we have about 4 more questions and about 4 more minutes.
Okay.
So you can put the next one up there, Josh. Good evening. A relative began having seizures at 18 years old after receiving an injection at a medical institution. He has been on medication since then, over 20 years. Is this epilepsy or seizures? I suppose the first line there,
I mean...
Let's say a relative has been having seizures at 18 years. We may or may not be related to injection. We don't know. But he's been on medication for this problem for over 20 years. Is this epilepsy or seizures?
Well, first of all, based on
It's a good question, though.
It's a good question.
Yeah.
It's human nature when you have a medical problem to do your own investigative work, meaning what happened around the time.
Oh, yeah.
So this patient or viewer may think that there was a relationship between the injection and the seizures. What if there was a prelude to that epilepsy and the doctor gave an injection to fix that? So I don't think you can ascribe the cause as the injection. I think it may be incidental.
Yeah, that's a very good description of what I was just trying to say there as well.
But in terms of, is it epilepsy or seizures? Likely epilepsy.
Likely epilepsy. Because?
Because it's recurrent.
And we've been on for so long.
And I'm sure they would have done lots of tests
at this point in
to
time
see if there was something else causing it.
Okay. Next question there, Josh. Sorry. Hello, good night, Dr. Panday. How come some children get febrile seizures? This question is a great question, while others don't. Thank you and great show. Well, Doc is not really a pediatrician.
I'm not a pediatrician.
But you're a neurologist and you've seen this with kids.
And I'm going to venture.
And you have 2 young kids as well.
Yes.
And as a parent, speak to those parents out there.
I'm going to venture to discuss this, but I would defer to the expertise of a pediatric neurologist. But in my experience, not everybody with fevers get seizures. A febrile seizure is a seizure in the setting of a high fever.
Yeah. So that's why typically in the community, the lay person might say, child fever gets so high that they get a seizure.
And that's actually a very good description. Now, not everyone with febrile seizures need to be treated, and the vast majority of patients with febrile seizures never go on to have epilepsy.
When you say treated, you mean for epilepsy, yeah?
Absolutely. Oh,
right.
Yes.
Yeah.
So if you've got febrile seizures, it means you've got a high fever, your brain could not process it, and the mechanism of your body dealing with it is the convulsion. All right? Now, there are some genetic causes of it. So some patients are more genetically predisposed to febrile seizures. They tend to have a family history than other patients. So not everyone with a fever will get a seizure. And this is a reason why you should treat fevers. You should not allow high fevers.
Exactly. You treat seizures, fevers and seizures.
And you treat the cause of the fever. So you see your physician to determine if it's a virus, something going wrong, if it's a bacterial infection, that sort of thing.
Yeah. Josh, give me a little feedback there, please. Question for Dr. Panday. What is the relation between thyroid and memory loss dementia? I suppose it's thyroid hormone irregularities.
Yes, that's a very good question.
Okay.
And the reason why is because whenever you diagnose someone with dementia, it's a neurodegenerative condition for which there is no cure. So you want to be absolutely certain that you have not missed a reversible cause.
Yeah, and condemn someone to...
Absolutely. So thyroid, or an underactive thyroid, will give you symptoms of depression and dementia. So that's why whenever a patient exhibits features of that, we check the thyroid. Conversely, if you have an overactive thyroid, you will get similar symptoms but accelerated. So it is critical when a patient is not at their baseline, you check that thyroid
hormone.
Exactly.
Yeah, I'd like to throw in electrolytes as well into that picture.
And B12.
Yeah. Josh, we have another question. I think it's the final question. Excellent show, very informative, and explanations are simple to understand. Well done. Well, I think.
And that one.
I think that's a good way to wrap up the show there, Doc. So, Doc, I'd just like to give you the final word. Just speak a little bit. We spoke about mostly seizures and epilepsy and about Parkinson's. Just in general, to people out there who sometimes these conditions and the way that the society is and the way that the world is and coming out of the pandemic, people lose hope a little bit and it gets sort of get down with the medical conditions, thinking that is all bleak. Someone like yourself came in tonight, very pleasantly explained everything and brought hope. Just say 2 words to the public out there who might just need a little bit
patient
of
education,
reassurance.
Patient education and patient empowerment is critical to managing a patient. So, for example, many patients lose hope because they don't understand their illness, nor do they understand the goals of treatment. If a patient may have an illness for which there is no cure, but understands what's wrong with them, understands the treatment, understands the goal of care, and gets the family involved in this discussion, the outcome is going to be better. So never lose hope. Get educated.
Well said, Doc. Josh is just telling me that one or two patients wanted to have an idea of a contact, how they could reach with you.
I'll speak with that off air.
All right, okay. You could give that off air. All right, no problem. Thanks a lot. All right, guys, so we've come to the end of the program. It's really interesting. Very stimulating discussion between myself and Dr. Panday and yourself as well at home. So I'd just like to thank Dr. Panday for coming in tonight. It was great having him. And I would just like to thank you at home for joining us tonight, for sending in your questions, for keeping the discussion going, for furthering the education, and for keeping this program moving forward. All right, guys, so you have a pleasant evening, have a pleasant night. Take care of yourselves. We'll see you again next week, and God bless everyone. Take care now. Thanks, Doc.